Hey everyone, my name's Elena and I have Callie and Hannah with me today, and we are presenting our autism case presentation. So we have case history number 5, and his name is Phil, and he's a 16-year-old male, and he attends a local high school and performs well in his class. He is able to remember and recast numbers and dates, recall dates from history, and recall personal information about a person up to 5 years after meeting them. And the other characteristics that was presented in the case history will be discussed in the upcoming slides.
Okay, so for his identifying characteristics and behaviors, after evaluating the client based on his case history, the following key characteristics of autism were identified when compared to the DSM-5 autism diagnostic criteria, and those were echolalia, atypical speech characteristics, which is robotic tone, over-articulates his words, insistent on sameness, inflexible adherence to routines. He has some fixated interests that are abnormal in intensity or focus, and abnormal social approach, which was exhibited in his case history that he has some difficulty in back and forth conversation. Okay, so echolalia is when an individual repeats words or phrases they have heard, whether it be an immediate repetition or something that was said to them days or weeks earlier. Echolalia is often found as a sign of autism spectrum disorder. It is noted in Phil's case history that he often talks to himself and will repeat information over and over, specifically items said to him. From only evaluating the given information, it is very likely that the client exhibits echolalia. Atypical speech characteristics. What does it mean to have statico-like speech? Statico speech is when you speak in fragments of sentences that are punctuated by pauses, which interrupt the flow of speech. What does it mean to over-articulate your words? It is when an individual gives too much energy to the articulation of their thoughts. More emphasis is placed on each sound of a word, and it has caused each word to stand out more than necessary during conversation. It calls for a very rigid, serious tone of voice. Both of the listed atypical speech characteristics are often associated with autism spectrum disorder and can cause the individual's speech to be robotic, as if they lack empathy. Insistence on sameness, and inflexible adherence to routines. The following information was noted in Phil's case history that falls under two key characteristics of autism, which are insistence on sameness and inflexible adherence to routines. In his case history, it stated that he has very scheduled routine each day and becomes very upset when his schedule changes. For example, if dinner is not eaten by 6 p.m., he begins to ask over and over when they will eat and will start pacing the floor, repeating the question over and over. He keeps his room very clean and has a place for every item. He becomes upset when anything is out of place or has been removed without his knowledge. Fixed interest and abnormal social approach. The following information was also noted in Phil's case history that falls under two key characteristics of autism, which are fixed interest and abnormal social approach. He often talks about random topics in great detail that the conversation partner does not show interest in. Because Phil talks about random topics in great detail, it could be evaluated that he has a specific interest in those topics. It is typical for an individual with ASD to have certain topics they know a lot about and prefer to talk about during conversation. The provided information says that his conversation partners do not show interest in his topics. Therefore, it is likely that he has difficulty reading the facial expressions and nonverbal cues of his conversation partner. It is also likely that he experiences difficulty in successful back and forth conversation. These are all key characteristics that are commonly identified in an individual with autism spectrum disorder.
All right, and I'm going to talk about the assessment portion. So for diagnostic assessments, we decided to do the Autism Diagnostic Interview Revised. This is an interview for parents. It helps to provide some context and background for current concerns parents may have about their child. So for this is consisting of 93 items in 3 subscales, which measured communication, social reciprocity, can't say it right, restricted repetitive behaviors. And then the next diagnostic assessment we decided on was the Autism Diagnostic Observation Schedule 2. This was a standardized protocol for observing the communicative and social behavior. And this one allows us to collect firsthand information regarding Phil's symptoms and behavior to make a correct diagnosis. And this contains 4 modules, and this looks at the levels of development and language and to base it off of. All right. And so for this, for behavioral assessment, we decided to do the functional behavioral assessment. So with Phil getting upset about his routine schedule getting messed up we wanted to make sure we assessed whether or not this affects his academic performance when this happens and how we can better treat instances from happening. We know that just from his case history that the root cause of this behavior is due to sticking to a strict schedule, but we just want to make sure we rule out any possible hindrance to his performance at school. And so basically a functional behavioral assessment works as an assessment will occur at home or school. The parents are interviewed to find behaviors and their possible triggers. Next, he will be observed throughout the day to see how often the behavior occurs. A hypothesis is developed to the cause and effect scenario surrounding it. And then last, replacement behaviors will fill the negative behavior to serve as the same fulfillment for Phil. So for the educational assessment, we chose Psychoeducational Profile 3rd edition. This helps to identify strengths and difficulties in Phil. So with Phil having problems with several pragmatic areas, I just thought this assessment would be appropriate because it focuses on the maladaptive behaviors, which is an area that we wanted to definitely study of Phil's. So this assessment is conducted in 2 parts. There's the caregiver report, which the parents identify their child's developmental level in several categories in comparison to typical development. And then the next part was the performance profile, which is composed of 10 subtests. 6 of these measure developmental abilities. There's verbal, pre-verbal, expressive language, receptive language, fine motor, gross motor, and visual motor imitation. And then the last 4 subtests were to measure maladaptive behavior. There's affective expression, social reciprocity, I can't say it right. And then there's characteristic motor behaviors and characteristic verbal behaviors. And for curriculum-based assessment, we decided to do the assessment of basic language and learning skills. The ABILS is a guide to assessment and curriculum-based for children with ASD and other developmental disabilities. And it contains 554 items scored 0 to 4 across the categories of basic learning, academic skills, self-help skills, and motor skills. And we also wanted to do a speech and language assessment. So with Phil having atypical speech characteristics, we wanted to have a formal assessment for his language done. So we chose to do the comprehensive assessment of spoken language, the CASTLE. This consists of some different subtests that involve expressive and non-literal language and pragmatic judgment. And these help us to get a better grasp of how the child speaks and his pragmatics, grammar, and how he uses language to communicate with others. And it also looks at his articulation and volume of speed of speech.
Okay, so the next section is intervention. So evidence-based practices that should be implemented with this client. We chose visual support, and throughout the therapy session, a visual schedule will be implemented for Phil so he can see the activities that will be completed. And we'll also create a visual schedule for him to follow during school. And we also chose social skills training. Phil will frequently talk about random topics during conversation with his peers, and they don't show any interest in what he talks about. So we will implement social skills training for him to help him acquire and practice his social skills and communication to promote positive interactions with his peers. And then third, we chose social narratives. And so we'll also implement social narratives throughout the therapy session to highlight appropriate ways to respond in social situations. So, our long term goal, we chose that the client will exhibit age appropriate, expressive, receptive, and pragmatic language skills in order to communicate his wants and needs across all environments. Our short term goals include the client will engage in conversational turn taking with the clinician across 4 out of 5 opportunities with 80% accuracy. The second one is the client will exhibit appropriate intonation in conversation with 80% accuracy after modeling from the clinician. And this goal came from his case history when they talked about how he talks in a robotic tone, so we wanted to target that. And then our third was the client will transition appropriately from tasks and activities 80% of the time, given with visual and verbal prompts. So our materials for therapy would include visual schedules, games that feel likes, and picture cards. So our lesson plan, the first objective is that the client will engage in conversational turn taking given 4 of 5 opportunities. So, what will happen in that session? The clinician will review the visual schedule of the therapy session with the client before beginning the session, and we'll have that so he can see at all times, and so he'll know what's coming up next. And the clinician will provide the client with picture cards, and the clinician and the client will go back and forth to discuss what is going on in the picture. And so they'll have the client will have to stay on topic for at least 4 of the 5 opportunities given. The clinician will also provide verbal reinforcement for correct responses and give corrective feedback for incorrect responses. And then the client and the clinician would take a break after 10 minutes for a 2-minute game. And so our materials for that one would be for that first objective would be picture cards, a visual schedule, and Uno. And for our second objective, the client will use appropriate intonation when given topics of his interest with 80% accuracy. So the clinician will have 2 topics ready for Phil that interest him. And we already got this information from his parents. And so we already know what he likes. And so we already had it set up, and the client will use appropriate intonation while talking about the topic, and the clinician will model appropriate intonation for the client so he can see what is appropriate, what the appropriate intonation should be. And then the clinician will provide verbal and reinforcement for correct responses and give corrected feedback for incorrect responses. And then also the client and clinician will take a break after 10 minutes for a 2-minute game. And so we'll have Uno, a visual schedule because he'll have it there at all times, and picture cards. Okay, in our third objective, the client will transition appropriately from tasks and activities with 80% accuracy given visual and verbal prompts. So the clinician and the client will work together to come up with a booklet on coping strategies for preparing and transition between the task and activities. And the clinician will provide verbal reinforcement for correct responses and give corrective feedback for incorrect responses, and the client and clinician will take a break after 10 minutes for a 2-minute game. And so for this objective, we decided that the first session that we would come up with a booklet so he can have like the coping strategies, and then later on in the semester, since our short-term goal is given the time that he has throughout the whole session, we'll be measuring like everything that he does from the first objective to the very last objective. But for this sake, that we're just creating a booklet so he can have throughout the semester. And so our materials would be booklet, Uno, and a visual schedule.
All right, so I'm just going to talk about some of the support systems for children and their families. So family support. So typically after that diagnosis, we want to make sure we counsel the family on how to support the child throughout diagnostic, assessment, and intervention processes. We know this can be a stressful ordeal, so providing the family with tips on how to approach the situation can help ease and listen to their concerns. We want to make sure we counsel the family, caregivers, and teachers to make sure to be patient with his communication abilities, and to encourage him to try new things slowly. And we also will get the SLP, will provide coaching techniques to the family that we taught during therapy to him. And these will best be implemented both in therapy and at home. So it'll be important to enforce in both settings. So for the referrals, we would refer him to a psychologist. This would be to address Phil's social, emotional behaviors and social influences. The psychologist may have more strategies on how to address him getting upset in situations. And this would also be where Phil could learn strategies on how to address having a disorder while being an adolescent, which is hard for everyone. It is difficult to be a teenager, but even more difficult for people that have disabilities. And social influences are huge in teenagers, so we just want him to learn ways to handle his situation appropriately. And then I would also do a referral to an ABA therapist. This would be to see if they can assist him in improving his quality of life within Phil's daily routines. They focus on learning about his self-care routine, sensory issues, and learning strategies. And this would be to look at his abnormal social approaches and fixed interests and bring about meaningful behavioral change.
Okay, so for collaborating with other professionals, we decided that when collaborating with the psychologist and ABA therapist in the referral, we will implement an intervention plan to achieve the desired changes with Phil, along with his parents and teachers. I would like to have a teacher education. I would like to have teacher education on classroom management, providing training on how to do visual schedules and social skills training, along with encouraging appropriate transitions, are important to implement in the classroom and will help to improve Phil's chances of improvement. Also, showing the teacher how to provide visual and verbal prompting appropriately to Phil will help to apply intervention in environments. Okay, so support advocating for Phil. It's important to acknowledge the parent's possible grief for the new diagnosis, provide the parent with information on the referrals, set up a follow-up appointment, share evidence-based treatment options with the parents and Phil, provide information on how to tell others about his diagnosis, advocate for the client and their family's needs, whether it be due to the expense of therapy, time conflicts, family involvement, and what resources might be available to them. Be there for the client and counsel them throughout as needed, as well as the family. Okay, and that is all of our presentation. We want to thank you for viewing it, and that is all.